So what is the goal of mechanical ventilation? So let us take two scenarios. One is a classical patient wherein you have a 45-year-old male presenting with respiratory failure, having an ARDS, and patient is having a PF ratio of 87 on HFNC. So this is what is called as type 1 respiratory failure. We have seen extensively in our respiratory failure section. This is your classical for your hypercapnic respiratory failure wherein there is increased CO2. So in both of these conditions, what are we trying to achieve? So in this condition, we are trying to improve the oxygenation. In this also, we are going to improve the oxygenation. But the cause of worsening of oxygenation here is because of your excessive increase of CO2. So we want to reduce the CO2 here. Here we just want to improve the oxygen by improving the lung mechanics. So how does the ventilator know what to do and what not to do? So that is what we will see. What are the parts or what are the phases of a breath or ventilator parameters. So the aim of mechanical ventilation is in three instances. One is we want to improve the gas exchange, either oxygenation and carbon dioxide. We want to reduce the work of breathing. We will see how it reduces the work of breathing. So we have seen or we know that your major equilibrium point wherein your chest wall outward force of the chest wall and the inward collapsible force of the alveoli or the lung elastic recoil is balanced by one force that is called as a FRC. So that means when you are expiring, even at end expiration, there is some amount of gas exchange happening. That is what is called as FRC. So FRC is extremely crucial. One. Second thing, FRC with any modality of treatment, you want to improve the FRC. Once the FRC improves, your gas exchange also will improve. So thereby your work of breathing also will improve. Then it is also going to give us some time to treat the underlying lung disease. So if we ask you, what does the ventilator do? All that the ventilator does is it gives you time to correct the underlying disease that we have. It does not change anything abruptly. All that it does is it is going to give you some time for you to understand understand what is happening to the lung and correct whatever could be reversible. So what is ventilator? So we know based on your Ohm's law. What does Ohm's law states? V is equal to I potential difference across two ends of the circuit depends on the flow of current and the resistance of the circuit. So if I take the same concept here, so let us say one end of here is going to be the oral cavity or mouth and the other end is going to be the lung. So the pressure difference between this circuit will depend on the flow of air, that is going to be the resistive part, and there is going to be a flow that is going to happen. So this is what we are going to see. So you can apply force in two ways. Either you can apply at this end or you can apply it at this end. So if you are going to apply a force at the mouth end, it is called as a positive pressure ventilation. This is what is your current ventilators that are there. Similarly, previously they used to do something called as a negative lung ventilation or negative pressure ventilation. So what did they do was, this is called as a ion lung. So they placed the person inside a negative suction chamber. So once you are inside a negative suction chamber, you change the hemodynamics from the outside rather than inside. The problem with negative pressure ventilation, why it did not work well, is because of the fact that negative pressure ventilation, it was mainly done for neuromuscular disease like polio epidemic. But whenever you have a disease like ARDS, there is a huge swing or defect in the compliance of the circuit. Compliance is affected, resistance is affected. All of these parameters completely cannot be affected by a negative pressure ventilation. So it can just give some amount of support for muscular disease. Hence, it did not work well. So that brings us to the concept of the current modalities, which are positive pressure ventilation, which is a life-changing boon that we have got in the current era. So this is what is a typical ventilator screen that you would see. You would see a lot of waveforms here. You would see multiple parameters. You will see multiple knobs. So here, if I'm just trying to put it here, so in each ventilator, you will have three things. So one is the pressure. You can adjust the pressures. You can adjust the volumes. you can adjust the times. So you can use your IE ratio here for adjusting the time. So these are the only three parameters that we can play around with in any ventilator. So if you see a microstructure of how a ventilator, if you see that entire box that you see in your ICUs, so what does it contain? So this entire thing is what is your box and your circuit that you play around with. This is your expiratory limb and inspiratory limb. And then you have an artificial airway that connects the ventilator to your human lung or your airway. So pressurized oxygen is given. So normally your attachments, if you see, if you go and see your ventilator, you will have two attachment ports. One is to the oxygen and one is to the air. Sometimes you may not have an air. So if in that instance, what it does is you have some serrations or areas in the ventilator itself where it takes your ambient air from the atmosphere and causes a blending. And you have turbines that increase the pressures. Then it will sense how much is the oxygen, how much is the air circuit combination. And based on our settings, it will deliver it. Once it is delivering, you will have an humidifier. Why is this important? Because normally our lung has a function of humidification that is not being done in an artificial circuit. So to mimic that, you have your humidifier, very important. Because many times you'll have tube block and secretions. When you have copious secretion, you have tube blocks very frequently. That is very essential. And you can also have a discomfort, excessive discomfort if you don't have humidification. So these two things are very important. So this goes to the lung of the patient. And then during expiration, again, there is a sensation. It is sensed to the sensors and you can adjust the circuit accordingly. So how does the ventilator know how much to give, what to give, and how does the ventilator speak? So we are saying, I want so much amount of volume to go inside. But in ventilator terms, how does the ventilator understand it? So this is what we call as an equation of motion. So we know that our lung has an airway component. Our lung has an airway component and the alveolar component. So whenever I'm going to apply some amount of pressure here, so once the ventilator is applying a pressure, so let us say the ventilator is going to apply a pressure. So it is required to open up the airway. So we will take this as our airway component here. This will be our airway. So initial pressure has to overcome the airway. Airway is the maximum area of resistance. It is just a conducting zone. You don't have much gas exchange happening at the level of the airway. This pressure that is going to extend to the airway, it will also extend the alveoli. So if I take this as a ventilator, the pressure that is applied at the level of the airway or the mouth is your P1 and the alveolar level is your P2. So you have a component of resistive force, which is the airway, and the elastance or the compliance that is happening in the alveoli. So resistive force is given by the formula of flow, because you're just going to have a flow across the airway and you're going to have a resistance of the circuit. And elastance is going to depend on the change in volume per unit, change in the transpulmonary pressure. So that is what is elastance. So it is 1 by compliance. Elastance is 1 by compliance. So compliance is change in volume for change in transpulmonary pressure. So your distending forces. So for anything you want to change, either you can change your elastance, your resistance force. Okay. So if I have to rewrite this whole equation again, if I have to rewrite this equation, I can understand this by saying the entire pressure of the circuit will be equal to the pressure of the ventilator plus muscular pressure if this patient is spontaneously breathing. Otherwise, this will be zero. So that will be given by the formula flow into resistance plus tidal volume by compliance plus PEEP. So this PEEP can be overall PEEP, intrinsic PEEP or a extrinsic PEEP. So this is going to say indirectly that if sedated patient, this will be zero, or paralyzed patient, this will be zero. So water pressure of the ventilator will be depending on the flow. So this is something that we can adjust. Air resistance is part of the circuit. This cannot be adjusted. We cannot adjust the airway circuit resistance. We cannot adjust the compliance of the circuit. So all that we can adjust is the flow. We can adjust the tidal volume. We can adjust the PEEP. So if you are going to say, I am going to set one particular variable in the ventilator. So that is what is called as a dependent variable. So let us say I have decided I will set some X amount of tidal volume. So that means the target or a dependent variable will be what I set. Whatever I set will be the dependent variable. So we should remember that ventilator is a closed circuit. So it is a closed space. So whatever I change, whatever I give, will cause a change in the other parameter because I cannot change both. If I have to change the volume, the pressure will inevitably change. If I set the pressure constant, the volume will inevitably change. So if the volume is set, you are going to get something called as an independent variable, which is pressure. If I set pressure that is going to be a dependent variable, then volume will be an independent variable because it is a closed space. So if I give a pressure across the alveoli, you are going to change the volumes. So this is what is dependent and independent variable. This is very important to understand. So what do I understand by flow is what is the amount of inspiratory volume that I'm going to give in a time period. So this is what is flow. Okay, so this is what I have understood. Okay. Now, using this, we will generate some waveforms. For this, I will require a PPT. So I'll show you how in the PPT it will be able to understand better. If I take the ventilator, so ventilator is going to give a pressure. So one is going to apply the pressure. Once it is going to apply, so let us say I have set it in a volume control ventilation. So I will give a set amount of tidal volume. So once I'm giving this tidal volume, what is going to happen? The pressure is gradually going to increase as the lung is going to get distended. At one point, suddenly, if I say I will stop ventilating, so the maximum pressure that the ventilator circuit goes up to, that is what is called as a peak pressure. That is, your entire alveoli is distended. So that is what is called as your peak pressure. So the normal cutoff we say is peak pressure should be less than 40. So once it reaches its maximum, it will go into expiration further after this. So at that point of time, what I told you, so the equation of motion said pressure of the ventilator will be equal to flow into airway resistance plus tidal volume by compliance plus speed. Now, let us say at one time point, I make 0 as the airway resistance. In the sense, I don't give any tidal volume. If I don't give any flow, so what will happen? The flow and the resistance will be 0. So the resistive component of the airway will become 0. So the resistive force is becoming 0. So whatever is going to be there is going to be dependent on my compliance of the circuit. So this portion was your airway component. This portion was your alveolar component. So this portion became 0 when I'm not giving any flow of gas, is not there at all through the ventilator. Whatever pressure that the ventilator will sense will be the pressures here of the alveoli. So that is what is called as my plateau pressure. The point at which your airway resistance becomes 0. So that is what is called as your plateau pressure. So we say plateau pressure is going to dependent on tidal volume, compliance of the circuit, PEEP. So we have seen in ARDS section that the plateau pressure has to be less than 30. Extremely important. So how will you pick up this? So how will you calculate this plateau pressure? So on the ventilator, you will do something called as an inspiratory hold. Okay. So what do you mean by that is, I just press that inspiratory hold button. Each ventilator has a different mechanism. You should be well versed with what your ventilator, how to do it. So this is there in every ventilator. So you'll do it for 1 second. 1 to 2 seconds is what is maximum that you should do for. So once you do an inspiratory hold, once you will do an inspiratory hold on the ventilator. So I was telling you about inspiratory hold. So once you do an inspiratory hold, this is gone. So whatever is going to be here is this. So 1 to 2 seconds. So this is what you're going to get. So what they may ask you is, how do you get your plateau pressure on the ventilator? This was asked in my DM interview. So they asked me, how will you calculate your plateau pressure on the ventilator? So you should say you do an inspiratory hold, the ventilator will give you this value. So now we have understood the total peak pressure. This is going to be my total peak pressure, right? So this is the maximum pressure that the ventilator circuit has achieved. This is my peak pressure. Next, what I have is my plateau pressure. that we have seen. So the difference between peak pressure and plateau pressure, what is this called as? This is your trans airway pressure. It's called as a trans airway pressure. So is it very difficult to understand? You have taken the entire circuit pressure. So this is what is your PIP. And I have taken only this component, which is the plateau. So the difference of this is what is trans airway pressure or TAP, trans airway pressure. So you can calculate your resistive component, airway pressure by using this. Next. This you have understood? No. There can be multiple instances where you have your troubleshooting in the ventilator. So let us say in this instance, what we are seeing here, your peak pressure is high, peak pressure is high, plateau pressure is normal. So when can you have this? When can you have this? Think of it. Your peak pressure is high, plateau is normal. That means anything that is going to affect your airway flow, that is what is going to cause your issues here. So you can have from outside to inside, you can have your excessive amount of secretion, you can have your tube block. How else you can have this? You can have your expiratory limb that is blocked, or there can be circuit issues. So all of these are common causes. Okay, or you can have your bronchospasm. Very commonly, you will see all of these instances in the ICU. Most common is bronchospasm, tube block, secretion. So how will you reduce this? You do a good bronchoscopy, it improves. So once you remove the secretions, your pressures reduce, or you give a good amount of bronchodilators, your bronchospasm reduces. You change the tube, this will improve. This is done. Next, you have peak pressure is high, peak pressure is high, plateau is also high. What can this say? It is going to say your total pressure is high, your plateau is also high. So this is because of your compliance issue. Compliance issue. Okay. So this is what we have understood. So you can have things like ARDS, you can have your pleural effusion. So all of this is going to cause compliance issue. So once you have understood this, so causes for this can be asked. And you can also do it on a ventilator. Increased plateau plus increased PIP or increased PIP plus normal plateau. So these two instances they may ask commonly in your entrance exam. Expected questions. And it is simple to understand as well. Okay, so this once you have understood this, we'll go to the next component. That is how is the ventilator going to this we'll understand the language of the ventilator. Now we have understood the main concepts. So what are the parameters that we have seen? The parameters in any mechanical ventilation. The parameters in any mechanical ventilation is going to be equation of motion. Flow into resistance plus compliance plus PEEP. Extremely important. This is one thing that you must remember. Okay. So this PEEP, it can be of two types. One is called as an auto PEEP that is commonly seen in conditions like COPD, or it can be your applied PEEP, or it is also called as extrinsic PEEP. This is also called as an intrinsic PEEP.